Okay, we move on to the next speaker. It's Professor Richard Dillon from King's College in London. We still remain on the same topic, t-APL, and the topic, so the title of the presentation is Clinical Presentation and Outcome of t-APL.
Thanks so much for having me, and thanks for organising this wonderful meeting. It's excellent. I'm Richard Dillon from Guy's Hospital in King's College, London, and I'm continuing on the theme of therapy-related APL, which it's a very rare condition, but as you saw from the previous talk, it's really fascinating, and there's probably a lot of lessons that we can learn that apply to other types of therapy-related leukemias. So here's what I'll cover during my talk. First of all, the fact that the frequency of therapy-related APL appears to be increasing, as you touched on, and then just review some of the literature regarding the clinical features of therapy-related APL, focusing on, in particular, the advanced age of the patients, latency period between treatment and onset, and the types of prior therapy that patients have had. And then I'll review some data on the response to therapy. And this is particularly relevant in APL because, of course, we have now chemotherapy-free approaches. And then finally, I'll talk about how that could be relevant to the treatment of other types of therapy-related leukemia in the future, particularly, hopefully, as we're going to get more targeted approaches and potentially even chemotherapy-free approaches in the not-too-distant future for other types of therapy-related APL. So first of all, the frequency of this condition within APL, as you saw, this is perhaps rather high. So the key thing to say here is that all of these studies use this kind of clinical definition of therapy relatedness in that the patient has ever been exposed to any type of cancer treatment. And there are three large studies that have tried to look at the frequency of therapy-related cases within APL cohorts. And you can see here that the frequency ranges between about 5 to 15%. And there's some evidence that this could be increasing over time. And this is unsurprising, mainly because of the fact that the rates of survival from almost all cancers are increasing quite significantly. You can see this slide, which is looking at the 5-year survival from all the different cancers between 1970 and 2007. And you can see that for almost every single cancer, there's been really quite remarkable increases in long-term survival. So if you're feeling depressed about the state of the world these days, I think this is quite an amazing achievement for medicine. The second thing to say about these therapy-related cases is when we use the clinical definition, of course, not all of the cases that arise after exposure to cancer treatment are actually going to be biologically therapy-related. You saw the epidemiological evidence for that yesterday from Lena's presentation, but there's also some molecular evidence, I think, because as you can see, this is looking at the mitochondrial-related cases. Of course, a lot of them do cluster in the mitochondrial breakpoint, but also a number of them are sporadic, indicating perhaps that they arise just coincidentally, and it's a different mechanism that's underlying leukemogenesis in these cases. So I'll just review some data on the clinical features of patients presenting with therapy-related APL. Including the 3 studies mentioned earlier, but also 3 other large intergroup studies, which were also included in Tiziana's presentation. And the key thing about these patients seems to be that they're substantially older than de novo AML. So if you look at the median age at presentation of therapy-related cases, this appears to be mid-50s to 60. Compared with de novo APL, which is approximately 40 years old. So the patients are about 15 years older. And in the studies where multivariable analyses have been done, actually age is the only consistent clinical feature that's significantly different between the sort of clinical features of these cases. And you can see that in the study on the right from the Jemima group, actually, not only their age, but also there was a substantially greater proportion of patients with performance status of 3 to 4, 24%, compared with 3% in de novo cases. So this reflects not only the older age of the patients, but also we know that exposure to cancer treatments results in all kinds of long-term effects on your health. And I think so that this decrease in performance status reflects not only the older age, but also the fact that the patients have suffered from various toxicities from different cancer treatments. So this is a very important thing to bear in mind later on. We come to talk about the treatment. In terms of the latency period, this appears to be rather short. The median latency reported by these studies is between 2 and 4 years. And you can see on the right-hand column that there are cases arising actually within a few months of treatment. And this probably relates to the mechanism for leukemogenesis, which involves the direct formation of the chromosome translocation, as you have described. But also you can see that there is a long tail of cases with very long latency periods out to 10, 20 or longer years after exposure. And these cases are much more likely to represent the ones that have occurred coincidentally in a patient who's previously received cancer treatment. As you said, all the studies indicate that breast cancer is the most common primary tumor associated with therapy-related APL, in some studies accounting for almost 60% of the cases. And this reflects the high and increasing cure rate from breast cancer in the relatively young age of patients at presentation. In many of the studies, the second most common primary tumor is lymphoma, although this is rather variable and actually decreasing with time. And I think that possibly reflects that the lymphoma treatments have hopefully become somewhat kinder and less toxic over time. It's in contrast to the preclinical studies that you nicely described. In clinical data, it's very difficult actually to pinpoint a single drug due to the fact that most patients have had multi-agent treatment. So, for example, you can see that quite a substantial fraction of patients have received radiotherapy only. And there's a question mark really about whether these are actually biologically therapy-related cases or whether they're arising by coincidence, and I think that's unknown. A large proportion of patients on the right-hand column, as you see, also have received a combination of radiotherapy and chemotherapy. So there's relatively few patients that have received chemotherapy alone, and of those, almost all of the patients have received multi-agent chemotherapy. So whereas biologically it's quite easy to pinpoint the topoisomerase inhibitors, mitoxantrone and etoposide as key culprits, in clinical data set that's much harder to see. So moving on to the response and treatment of therapy-related APL. So I think the most comprehensive and a recent data set comes from this very nice European intergroup study led by Sabine Kaiser. What you can see is that, well, first of all, the response rates to treatment are very high. But secondly, the response rates are very different according to whether chemotherapy treatment or arsenic-based treatment is used. So you can see on the left-hand column, the complete remission rate with chemotherapy ATRA is 78% compared to 100% in patients treated with arsenic ATRA. The patients not achieving complete remission, 10% of them had partial remissions, but they subsequently went on to achieve complete remission with consolation therapy. But concerningly, you can see on the bottom left, 12% of these patients had early deaths. So we know that early death is a significant problem in APL, but actually in clinical trial data sets, the reported early death rates, this is very high. The typical early death rates reported in clinical trials is around 5%. And again, this likely represents the older age of the therapy-related patients, but also comorbidities as a result of exposure to prior treatment. And in terms of overall survival, again, you can see when the patients are grouped into whether they received arsenic-based treatment or chemotherapy-based treatment, there's a substantial difference in overall survival. The patients treated with chemotherapy ATRA actually, as well as poorer survival, there was 2 cases reported of a second non-APL therapy-related myeloid neoplasm after treatment for therapy-related APL. So these patients obviously, or all of these patients are unlucky, but these patients are exceptionally unlucky. So this is 4% of all patients in this study. You can see at the slide that Tiziana showed that chemotherapy-based treatments for APL, second therapy-related myeloid neoplasm, is an issue occurring in approximately 2% of patients. And on the right-hand panel, you can see that this is almost exclusively seen in patients over the age of 35. So perhaps the older age of the therapy-related patients puts them at higher risk of developing a therapy-related neoplasm after chemotherapy-based treatment for APL. This is the result from our AML-17 study. You can see on the bottom line the 4-year incidence of therapy-related AML after chemotherapy treatment for AML was 3%. And this was a randomized study between chemotherapy and arsenic, and there were no cases of therapy-related myeloid neoplasm after arsenic treatment. So we performed some translational research on this cohort, as you kindly mentioned. This was prompted actually by the observation that half of the cases that developed therapy-related myeloid neoplasm after chemotherapy treatment for APL had actually got therapy-related APL to start with. So we performed, first of all, we performed whole exome sequencing on the therapy-related and the de novo cases. And as you said, there was no difference actually in mutational profile between de novo and therapy-related APL, which we thought that was somewhat surprising, but perhaps not. We also then went on to perform targeted deep sequencing of all the genes that were mutated in samples from complete remission. And the observations we made here is, first of all, the blue color shows patients that we could detect mutations occurring in complete remission, which we couldn't detect at the time of first diagnosis. And this phenomenon has previously been described. So this is kind of chip clones that emerge after chemotherapy treatment. They could have perhaps been pre-existing, suppressed by the leukemia clone as it outgrows and then come back, or perhaps could have been initiated by exposure to chemotherapy. And we saw that both in the de novo and the therapy-related cases. However, interestingly, something that we only observed in the cases of therapy-related APL was that we could still detect mutations that were associated with the APL clone, so which were present at a high level of diagnosis. We could still detect these in complete remission, and these were MRD negative complete remissions with undetectable p-APL in a substantial fraction of the therapy-related APL cases. So to kind of illustrate the clonality of this phenomenon, I've shown here the variant allele fraction of all of the mutations at the 2 different time points. On the left, diagnosis of APL, on the right, molecular complete remission with undetectable p-APL. And you can see in these 4 cases that while the majority of the mutations in the APL clone are cleared at the time of molecular complete remission, in these 4 patients, a few of the mutations persist, including in all cases at least one putative leukemic driver, suggesting strongly that the therapy-related APL had occurred on the background of a chip-type clone. And this phenomenon was only observed in cases of therapy-related APL. We never saw this in any patient with de novo APL. And to investigate further whether this could represent pre-leukemic chip clones in which the p-APL subsequently emerged and caused initiation of frank leukemia, we injected the remission bone marrow samples into immunodeficient mice, and we were able to observe multilineage engraftment of human cells of both B and myeloid lineage, and we could also detect the chip mutation, but not the p-APL in the engrafting cells from these mice. Just to finish, I'd just like to sort of mention how this might be relevant to other types of therapy-related leukemias. And as Connie very nicely illustrated in her talk yesterday, there's really a move away from thinking about therapy-related leukemias as an entity to rather thinking about leukemias in their kind of molecular and cytogenetic classes, with a qualifier that the patient's been previously exposed to cytotoxic therapy. And this is seen both in the ELN scheme, as you can see here, and also in the WHO scheme, in which the term myeloid neoplasms post-cytotoxic therapy, and emphasize that these cases require full diagnostic workup, just the same as any other case of AML. This is also supported by some nice data that was presented in the last ASH meeting. And as you can see here, the overall survival of patients with therapy-related leukemias, shown on the blue lines, is not different than the de novo counterparts when considering cases according to their ELN risk groups. So on the top right, you can see therapy-related APL, which has no difference compared to de novo APL, as we know. But you can also see that this applies to both the ELN favourable, intermediate, and to some extent the adverse risk group. And in a multivariate analysis, you can see that therapy-related status is actually not independently associated with poor overall survival. And this study was mentioned yesterday, but this is a really nice recent European intergroup study looking at therapy-related leukemias with NPM1 mutation, which was led by Brunangelo Fellini. An analysis was done by Jad Offman, who's a leukemia fellow in our group. This study looked at 2,500 patients across the different European collaborative groups. For over 2,000 de novo NPM1 mutated AMLs and almost 100 therapy-related leukemias with NPM1 mutation. I'm sorry that something went slightly wrong with my slide, but RNA sequencing demonstrated that the therapy-related NPM1 cases cluster actually directly overlapping with the de novo NPM1 cases, in contrast to other therapy-related AML cases. And when we looked at the outcomes for these patients, it's very interesting. So the de novo NPM1 cases are shown on the dark blue line. The therapy-related leukemias without NPM1 on the grey line. The therapy-related leukemias with NPM1 are shown on the light blue line. So what you can see is initially there's a very sharp drop-off, which follows the trajectory of the therapy-related leukemias, and this is predominantly due to early deaths from toxicity. So, and about 1/4 of patients we lose actually in the first 6 months, mainly due to toxicity in these patients. But however, for patients surviving that period, their survival then starts to mirror the outcome of de novo leukemias with NPM1 mutation. And we can account for this by on the left by doing a landmark analysis for all patients that survive to 60 days, and on the right by looking at relapse-free survival. And you can see that these both exactly overlap de novo leukemia with NPM1 mutation. So I guess there's two really important implications from this work. First of all, the patients are much more prone to treatment-related toxicity, and this is a very important cause of death. And this, I mean, as we have done in therapy-related APL, these patients may well benefit from attenuated treatment protocols, and potentially in the future, hopefully, the introduction of more targeted treatments, even eventually chemotherapy-free approaches. And the second is that we need to treat the leukemia primarily according to its molecular and cytogenetically defined class. So in summary, we've talked about the rising frequency of therapy-related APL, primarily as a consequence of the rising number of patients who are cured from their primary tumour. We've spoken about the clinical features of therapy-related APL, and predominantly the main clinical feature of which is that they're older age, and poorer performance status in general. The response to treatment, which is excellent, but with the caveat that these patients are particularly prone to treatment-related toxicity and early death. And also that they may be at a higher risk if exposed to chemotherapy of a second therapy-related leukemia, which is almost always fatal. And finally, we touched on the relevance of this to other types of therapy-related AML other than therapy-related APL. Thank you very much. Thanks again for having me.
Questions? Yes. Can we have a microphone here?
No, giù, qua.
Thank you very much, Richard, for this great talk. I have a question. So I mean, it is striking that for APL and also for the NPM1 mutated therapy-related leukemias, that there is, in contrast to other leukemia types, that there is no difference with regard to the overall survival and the outcome. And so my question is, do you have any hypothesis, idea why this is the case? And I guess that in these two subtypes, the TP53 is not so dominant as in the other leukemia types. And do you know from the Ottman study if maybe the NPM1 genotype, that means with regard to co-mutations, FLT3, IDH, is this something that he looked in when he did this analysis? Sorry for these many questions.
That's okay. The FLT3 co-mutation was somewhat lower in the therapy-related cases, but it wasn't significant, and there was no difference in any of the other mutations. So what we kind of thought was that these are not truly therapy-related leukemias biologically. They're just de novo leukemias that are occurring in patients that have previously had chemotherapy, and the therapy actually has no role in initiating the NPM mutation. It may have had a role in development of a chip clone, for example, but actually the main feature of these patients is that they have had prior therapy exposure, so systemically they're vulnerable to higher toxicity. But in terms of the leukemia, our hypothesis is that biologically that's simply de novo leukemia. But of course, it's very difficult to further prove that.
Thank you, Richard. You mentioned a set of mutations that persist in the context of an MRD negative complete remission. And I saw that among patients with de novo APL, there were few with p53 mutations. And I mean, I'm not an expert, but I wouldn't expect such an association between APL and especially in CR and p53 mutation. So can you comment on this category? How this mutation, p53 mutation, affect the clinical outcome? Are there pathogenic mutations or what else? Thank you.
Yeah, you've got eagle eyes because it was in quite small writing, but you're right. We saw p53 mutations in 2 patients in complete remission. They were both de novo APL that had chemotherapy treatment. The p53 mutation was not in the APL clone. It came up, so it was not present at diagnosis, or it may have been present at diagnosis under a level below the limit of detection, and it emerged after treatment. And actually, both of these cases with prolonged follow-up ended up developing therapy-related leukemia. So it was a kind of the phenomenon that you saw in the ovarian lecture, where therapy is sort of expanding the p53 clone in those patients who are then at very high risk of therapy leukemias. We didn't see any cases of APL with p53 in the leukemia clone.
So I have a question actually, which is similar to the one that I wanted to ask to Cataldo Russo. Is given that there is a relatively high frequency of developing t-APL, in particular groups of patients, you showed breast cancer, for example, and within breast cancer, basically patients that undergo certain types of therapies and have a particular predisposition to this. So is it really inconceivable to set up a sort of monitoring program to make an early detection, an early diagnosis by chip or by measuring clonal hematopoiesis, or also by liquid biopsy, for example, for PML rare translocations? Because given the lower and lower cost of this type of assessments, it should be something to be applied.
I think it's a really good idea. And actually, we've been working with our breast oncologist to try and to set up a study looking at the actual incidence and natural history of these patients, and with the view eventually maybe even in the future, if we can identify patients at particularly high risk, there may be interventions that they can do. So they potentially considering the use of those p53 stabilizing drugs in patients who've got p53 mutations. We didn't manage to get the study funded so far, but we've been applying to try and do that. You're right, the costs are coming down, but still the cost of doing that, the incidence of breast cancer is very high, and there's a lot of patients, and the cost of doing that kind of study is rather high. But I definitely think it should be done.
There is a question here.
Richard, from Professor Leone.
You show that NP1 mutation is a favorable factor in therapy-related leukemia, like de novo. In general, in de novo, there is not cytogenetic alteration. It is the same in the therapy-related, because in general, in therapy-related, the cytogenetic alteration are very frequent, and then the spirit of the question is the mutation of NP1 reduce the negative prognosis of the cytogenetic or not, because it was been simple to, it is a group without cytogenetic alteration, and then are the cytogenetic the cause of the good prognosis, not the NP1.
Yeah, I understand. So there were cases with abnormal cytogenetics, and there were a few cases with adverse risk cytogenetics. So the whole group of the therapy-related NPM1 is 100, and this is including, what was it, 5 European groups, because it's quite a rare entity. So I think we have between 5 and 10 of those had abnormal karyotypes. So it wasn't possible to say whether those patients had a worse outcome. But it's been quite well described with de novo NPM1 that an adverse karyotype and an NPM1 mutation is associated with a poorer prognosis. On the other hand, an abnormal intermediate risk karyotype doesn't have an effect on the prognosis. Whether that also applies to therapy-related AML with NPM1, it wasn't possible to say with our data because the numbers were too small, but there was no statistically significant difference between patients with normal and abnormal karyotype in that cohort.
Okay, if there are no more questions, we thank you again.